Hi, I'm Ben Matthews, lower limb specialist physio, and welcome to the Physical Performance Show.
And the winner is...
Failure is not an option.
I've had my ups and my downs.
Phelps with 10 meters left. 3 minutes too good. The crowd roaring. Freeman wins down.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome back, or welcome to another episode of the Physical Performance Show, brought to you by Physiocrem and Pogo Physio. I'm Brad Beer, physiotherapist by trade and training, and founder of Pogo Physio. As per the intro, the aim of this show is to educate and inspire you towards the pursuit of your own physical best. We do this through interviews featuring some of the world's top physical performers and also some of the world's preeminent experts in their chosen field. Each week, we'll bring you the highs, the lows, and the learnings of our featured guests. Now, today's episode is one of those expert editions. Today, I'll bring you a conversation that I had with Benoy Mathew. Benoy Mathew is a UK-based extended scope physiotherapist who works out of the prestigious Harley Street Physiotherapy Clinic. Benoy has a special interest in all things hip and groin pain. Benoy is sought out in London for his expertise in this area, and it's for that reason that I wanted to bring you an expert edition on this so important region of the body. And on today's episode, Benoy shares key learnings around how to prolong the health of your hips, what can go wrong with the hip and groin, the role that imaging plays in diagnosing hip and groin pain, why it's important to act on your hip and groin pain quickly, as well as the best treatment approach to getting on top of hip and groin pain, including the best exercises and very practical advice for the running community experiencing hip and groin pain. So there's a lot in this episode. It's an expert edition. Get ready for a pen and paper with Benoy Mathew, extended scope physiotherapist with a special interest in all things hip and groin pain. Let's jump right in. Listeners, this is a real treat, an expert edition on all things hip and to some degree groin-related injuries. And this gentleman I first came across on a practitioner podcast that I keenly follow called The Clinical Edge. And Ben Matthews really caught my attention with his ability to articulate things very clearly in what is oftentimes a very complex and sometimes poorly misunderstood area of the body, and that is the hip and groin. So, Ben, thank you for joining us.
Thanks, Brad. It's great to be here, and thanks for the invitation. Real pleasure.
Ben, let's start with you personally and professionally. Tell us a little bit about you and what you do and what a classical week looks like in the life of Ben Matthews.
Yeah, so I'm a physiotherapist based in London, work in central London. So for the last 15 years, I've been sort of specializing in lower limb. So prominently my caseload involves runners, hip and groin patients. So it's more like a second or a third opinion. So it's sort of by accident I fell into hip and groin when I started my new job into lower limb around 10 years ago. So it's an area which I enjoy immensely. So I'm a full-time clinician. So I work into both for the NHS and private, and predominantly all my clinical caseload is exclusively lower limb. Do a little bit of teaching. So normally I teach at least, along with my friend Glenn Robbins, we teach at least 2 courses a month. So I think this year we're doing at least 12 to 14 countries. There's a plan we might be coming down to Australia in October or November. This year I've started dabbling in a little bit of research as well. So we just got a news that along with Mike Riemann, we just successfully had a publication accepted. So a bit of everything. So clinician, teaching, and I'm also a UK master trainer for Shockwave as well. So a real mix of different things.
And geographically, Ben, based there in London?
Yeah, pretty much. The clinic, Harley Street Physio, is based in central London. So, that's sort of my base there. I also work for the NHS as an orthopedic practitioner, linking with consultants, ordering scans, more like an advanced role, which sort of really enhances my private practice. So I get the best of both areas, dealing with frontline patients as well as dealing with consultants as well.
Yeah, so it's a very, very full week. What got you into physiotherapy in the first place, Ben?
Yeah, it's pretty simple. My two uncles were were physiotherapists, and when I was a teenager, I just shadowed that in the summer holidays, and I found making a big difference for injured patients. That was more like a burns unit and pediatric unit, so I could see the real difference getting them back into function. And I had multiple knee injuries, skiing accidents, ended up with major surgery. So I had first-hand experience as being a patient. And then decided that's what I want to do. So it just I felt like I can make better difference the way I was fortunate to have physio myself.
And that was not too indifferent with my introduction to the profession. But what were the knee injuries, just out of pure interest, Ben? Yeah.
So it was so quite a difficult one, which took around 6 years to diagnose. So I had like multiple skiing accident, and then I thought it was a meniscal tear, and I had 4 MRI scans which came as normal, and then I was put in a chronic pain group where I was told that it was sort of because I was 19, 20 at that age. So I just didn't have knowledge. And then finally they went for a diagnostic scope, and I had a massive chondral lesion. And then I ended up with microfracture, which failed. And then finally I had MAACP, which is the stem cell implantation, which has got back to work. So I had like 4 major surgeries. I think that's really made me relate better with patients. So I wouldn't really change that in any way, because you understand the sort of the difficulty patients go through, and also the periods of self-doubt where I had for many years, where I couldn't really get the diagnosis, and I was told by multiple practitioners that you just need to get on with it.
Gosh, that's fascinating. The chondral lesion or cartilage lesion, was that just out of pure interest of the femur there, was it? The lateral femoral condyle? Yeah, it was. Yeah, it's the medial femoral condyle, and because looking back, the MRI scans were of low resolutions, and it really didn't pick up, and it was quite typical. Like I used to only get pain around the 20 to 30 degrees of flexion, very focal when I did a squat or when I went uphill running. So very specific. I could reproduce it, but there's nothing else. It never swelled up. It never did anything. So it's a very tricky one where you could easily miss it. So now I can pick it up quite easily when a patient says that they have a particular angle where it catches them. Yes. So usually around that 20 to 40 degrees. And it behaves like early OA. When you run or sprint, it swells up a little bit the next day. But then it's so mild that you could easily miss it. And all the clinical tests are negative. So it's only when I added, at the time I was doing a lot of badminton. So whenever I did any plyometrics or badminton, it just swell a little bit the next day and ache for 5 days, and then it's back to normal. So it's very specific to high impact loading. So I'm sure there's thousands of people who have that similar symptoms where you can't really put that pinpoint of where it is. So it's sort of a tough one to really pick up, I guess, especially if you're a junior physio who's not seen that sort of condition before. It's interesting. We do have a bit in common here. I have had trochlear groove cartilage lesions on both my knees, and went through a somewhat similar process with microfracture of those, believe it or not. So how's your knee now? How's your knee now? Yeah, the microfracture didn't really work well. So I think now I'm at around 80 to 90% better. So I've started back running. I could do I'm sort of the typical where I'm very, like knee injuries, I'm very volume sensitive. So if I keep my running less than 10K and less than 3 days a week, I'm happy. My knees is happy. The moment I increase my volume, I'm okay with speed. Funny enough, when I increase speed, I'm okay. But the moment I have an increasing volume, my knees lets me know. So, I'm very pleased that, I'm pretty much pain-free during ADLs. Yeah. So I pretty much know my limits, my threshold, where I keep it going.
touring. So once you have kids, you're not really looking at performance. It's about being pain-free touring ideal. So I guess the knee things, when you have multiple surgery, it's very rare to be 100% back to normal. But as long as you're pain-free with your normal and it doesn't swell up and you don't have night pain, I'm more than happy to accept that, and your limits, isn't it?
Yeah, there's a lot there in what you just shared. Just before we move off that, how long were you off impact loading or running for after a cartilage graft like the MAACP?
Oh God, you're 6 weeks, non-weight bearing, and I could just cry seeing my quads getting atrophied. It's not, you could really, at the time I didn't know, the techniques like neuromuscular stimulation or BFR or things like that. So there's nothing really. I think it was 7 to 8 weeks of non-weight bearing, and it was 2 years of rehab.
Yeah.
With that procedure, and the first procedure failed as well. So sometimes you can't really. People think stem cells are easy, but it's not. The rehab is extensive, and there's no guarantee as well that it can work as well. But as I said, you don't have a choice really. You can't live a life like that, and when you're young you want to give it a best shot. So fortunately I think I had a relatively good result. But I think, as you know, when you get back that sort of lesion, it's very unlikely to get back into competitive sports or plyometrics and things like that. You always have some small niggling injuries, but the surgeon did inform me that it's not going to be 100%, but you accept what you're given, isn't it?
So much there, and I think let's just go on to the psychological, impact of injury. Benoy, you mentioned the self-doubt, the long periods of self-doubt. I guess quite a period of confusion around diagnosis. So I often say, Ben, we don't deal with people's pain. Obviously, we do as physiotherapists, but we're mainly dealing with the psychological unrest that comes with deficits in their activities of life, and also their ability to perform whatever it is they want to do sporting wise. So what would you say to that for listeners that are in this case hip pain? They feel like they haven't got a clear diagnosis, they're confused, they're fearful, they're anxious. What would you say to speak to that side of the healthcare? I think I'm always a bit cautious on the first session to assess, because I think you don't want to dive in, because some patients might say, I'll come here for hip pain. So I usually use some trick questions too. So one of my questions is I usually ask them simple stuff like, how does your hip pain affect your life? And usually they say, it's not so much. And a lot of one of the things which people, say easily, like something which I picked up with female patients is, especially with the labral pathologies, nearly 90 to 95% have severe problems with sexual life. So especially the female patient with hip problem, I always ask that, do they have normal, intimacy, and how does it affect their life? And also the biggest concerns, nearly all my hip patients have biggest fear that they'll end up having a hip replacement. There seems to be that fear in the media, or they look up and think, I got hip impingement, I'll end up I'll need a replacement. So I'll always ask them, what concerns you most? And usually it's like, I need a hip replacement. So I try to sort of diffuse that straight away. And then, then you can, most people are really relieved when they know they have a diagnosis, because usually they've seen multiple practitioners, and when they come to me, they're quite relieved and say, I'm so glad that I can find something is wrong, and they're happy to move forward. Sometimes you need a formal diagnosis to move forward, rather than using terms like non-specific hip pain or syndrome or things like that. So that's where I think the diagnosis and the imaging. And the big problem with hip and groin is, this is something I've stopped even reporting now, is you can get multiple X-rays and MRI which come back as normal. So it all depends on your expertise. So I'll give you a simple case would be like dysplastic hips. Usually they come back as normal. So I'm used to seeing them all the time. So just because it's been reported as normal doesn't mean that it's always normal. So it's good to get a specialist second opinion. And sometimes you can't find anything, but getting that sort of second or third opinion
for a diagnosis makes a big change. So it's pretty much tricky, and especially if you had a hip and groin. And to put that in a perspective, if you look at the quality of life of hip impingement, it's pretty much the same as somebody with a hip osteoarthritis. So these are people in their 20s and 30s who should really be active, enjoying their lives, spending the time with their families, kids who really have such a poor quality of life, limping, struggling, and somebody like with a hip OA in the 60s and 70s. So massive impact on their quality of life, which sometimes we can ignore because they might look fit, they might be going to the gym, but from an impact point of view, it's as severe as somebody with hip osteoarthritis.
Yeah, that's a fascinating insight. I'm just backtracking for a moment. I think that brings probably a lot of hope and freedom for some people listening in, that, even though sometimes imaging reports do come back as, no abnormality detected, nothing significantly is identified or significant is identified, they are fallible. There is times where, like yourself, you had 4 MRIs and that cartilage lesion of your knee wasn't picked up. So, as you say, I think it's a good time to encourage listeners, if you are seeking a diagnosis and haven't got it, then keep pursuing it and maybe look to other people, as in your case, a hip focused professional or an expert in a certain area.
Yeah, definitely, because I think this is a very niche area. It's only really picked up in the last 7 or 8 years, and I think looking back, I must have missed a lot of hip patient because I just went with the X-ray report. So I've I always insist on seeing the images myself. Because I work in an MDT where I'm working with a consultant radiologist, so we share and discuss the cases. So because everybody's fallible, so you can easily miss things. And once you've seen like few hundreds and thousands, you can easily pick up those sort of patterns. So if you have a consistent history and you got a clear pattern, it's always good to pursue that sort of option. And also sometimes you might need a diagnostic hip injection to know. So for example, like if you look at labral tears, for example, 1 in 2 people without hip pain have labral tears on the scan. So just because you have to look at both ways, just because you have a labral tear on the scan doesn't mean that is the cause of symptoms. So you might need, for example, a diagnostic hip injection, which when you had an injection and your pain is reduced by 50% or more, that again confirms. So it's very rare that any hip and groin patient is going to get a diagnosis with just one investigation. They might have an X-ray followed by, so just to give you a typical a journey, a patient who comes to me might have an X-ray initially. I might order an MRI, and by the time they go see a surgeon, they might have a CT scan, they might have a hip injection, and after all that, maybe 4 or 5 months down the road, it might take them to give a diagnosis. It's not something you can give on the first session. So it needs a collection of investigation, it needs a detailed history, and it might need multiple practitioners. So it's very rare that you can jump in and say, okay, you got a labral tear on an MRI. The most difficult part with the hip and groin is to confirm whether the source of pain is from the hip or is it an incidental finding. So with imaging, it can work in both ways. You can find an incidental finding, or you can have a finding which has not been reported. So that's why a teamwork is the best way forward.
And to bring perspective around that incidental finding, Ben, you're referring to something on imaging that's reported, but it isn't part of the patient's pain.
Yeah. So for example, let's look into labral tears. So many patients come to I had a young guy, who came with a typical adductor. He plays weekend football. Your classical adductors, pain in your thigh, pain on the squeeze. So he had anything extra articular pain. So a lot of private patients in London, especially, jump into an MRI scan, and then lo and behold, he had a labral tear, and he was so petrified of the labral pathology. So and then I showed him there's the latest, I think, a systematic review by Josh Harry from Australia, which shown that anywhere around 50 to 60% of the asymptomatic population have labral tear. So obviously you have to put that in a clinical context. So I said to him, do you have any painful clicking or catching? No. Do you limp? No. Do you have night pain? No. So I said to him that you don't have any symptomatic labral tear. And I just showed him that your diagnosis is something different. So sometimes you just have to diffuse that sort of anxiety when people say, I find the biggest anxiety is usually around labral tears, where people think the tear needs to be fixed. And tear, just just like rotatory cuff of the shoulder or of the knee. It's no different. It's just part of age-related changes. And but the funny thing about labral tear is when it gets painful, it can really be painful. So it's $1 million question. Why does it become symptomatic in some and it doesn't become in others? So if you have a symptomatic labral tear, usually it's quite painful. You have painful clicking and catching. You have night pain. You tend to limp, and most will report pain during sex and severe drop in the performance. So these sort of things will make me realize it as a symptomatic labral tear as well. So it's like anything, it's the clinical history and the context. Just a random imaging finding doesn't really mean anything.
Yeah, thanks for sharing around that, Ben. We have a listener who is tuning in, and they've had some hip pain for some time, and that's pain. Let's start with pain in the front region of the hip as opposed to the side or the back. Can you enlighten us, Ben, as to what are the potential diagnoses that can happen in the front part of the hip there with an active population? And I'll let you choose how. I know clinically, if you're talking to professionals, you sort of talk about an intra-articular, extra-articular, and referred group of conditions, but I'll let you break it down how you like for the listener in terms of what can go wrong, so to speak, or what can happen in the front part of the hip. Yeah.
So let's look at from a perspective. Let's use an example of a runner. So because we get a lot of runners who come to my clinic with hip pain. So for me, I think the timelines are really important. So if you have chronic hip and groin pain for more than 3 months, it most likely the source of pain is within from the hip joint. So a timeline is usually useful. So many of the time, the patients who come to me, they have a bit of niggle for a long time. The reason they come is when it starts affecting their day-to-day. For example, they say, I have this bit of niggle stiff. I've always been told that I have got a stiff hip, but it's never bothered me. So when I go for a run, it was a bit, a little bit stiff for, a few hours. But for the last 6 months, it's become more and more stiffer. So usually the first thing which starts with any problem within the joint is that perceived feeling of stiffness, which usually happens months or years before actually it gets painful. Stiffness on the hip is not at all normal unless you have some pathology. So you're not supposed to feel any sort of ache. You can obviously feel pain around the muscles, but you shouldn't really have that stiffness the next day or difficulty in putting socks and things like that. So that sort of chronic history where it gets worse with training and the next day will always make me to suspect of the problem within the hip joint. And when you do think it's within the hip joint, there are multiple ways. So if you are sort of 40, 45 plus, more you are going to think of more like osteoarthritis first, what I call the early osteoarthritis. So let's give an example. So you could get a young guy who's done a lot of football or rugby when he's young. So he already had a bit of a dodgy hip. And then in his 40s, he starts to do some extreme training like CrossFit or ultramarathon or some speed-based session. So it'll start a bit of niggling there. And so that's, sort of subclinical osteoarthritis that becomes symptomatic. So that's one possibility. A bit more younger, then it could be a hip impingement, which is a well-recognized cause of hip pain, where you have this incongruence between the shape of the femur and acetabulum. And if it's a female patient, you're more likely to see extra-articular, for example, the glute med coming from outside of the hip. So the way I would go is somebody comes in, the timelines, the age sort of gives us a good idea. So if it's more than 3 months, you're going to think it's more likely to be hip joint. If a runner comes and said, like, I've started some hill session and I'm feeling a little bit of pain in the front and going to the thigh, more likely to be a hip flexor injury or a recfirm injury, which usually subsides with load management and appropriate progressive loading. So, but the longer things are, it's most likely to be something within the joint. And the most common are early osteoarthritis, hip impingement, and hip dysplasia, where you have a shallow socket, which invariably is women. About 80% of this condition are women. So, the big problem with these three conditions are they're very similar. All of them have groin pain. They develop the stiffness. They have a bit of limping. So it's pretty much clinically extremely difficult to differentiate between these three unless you had some X-ray or a specialist opinion. So generally I advise if your pain has been more than 6 or 8 weeks, it's reasonable to get a specialist opinion or have even a basic investigation like an X-ray. I would not rush into an MRI because you might get a nocebo finding like a labral tear. Now, On the other hand, let's imagine that you get a female runner who comes to your clinic who suddenly ramped up on a preparation to marathon running, and she feels a bit of severe pain in the night, and she is limping, and she stopped training. I'm always a bit suspicious of a stress fractures. So it's quite higher in a female runner whose BMI is less than 19. So sudden spike in training, and then you're going to be more concerned of bone stress injury. So in that case, an X-ray is pretty useless because you're not going to pick it up. So you might want to rush into an urgent MRI to rule out any stress reaction or fracture. So the only time I would rush into an MRI with any patient would be is when they have night pain and severe limping and drop in the ability to walk and hopping as well. So generally, if you put your hip pain in active population, you can put that into 3 groups. A red flag, which is sort of a stress fracture. Very rarely you can get metastasis of your femur, which is very rare unless you had a cancer before. Soft tissue injuries, usually the glute tendon, especially in a female, hip flexors, TFL injury. And if your symptoms have been more than 3 months, then I'm always suspicious of something within the joint. Now, the problem with the hip is it doesn't really spread in one location. In some patient, it could be on the side of the hip. Some people is in the front of the groin. About a third of the patient will be it'll radiate into the gluteal, into the buttock region. So there are 5 possible areas where you can refer. So most of my times when patients come to my clinic, they usually have this diagnosis as a tight hip flexors or a TFL, or their glutes are not firing. So I'm just sick of hearing this again and again, tight hip flexors. And so people are treated on that with a lot of hands-on and dry needling for 18 months or 2 years, and it's not got better. So if you have a nagging soft tissue injury which is not responding with good rehab and activity modification more than 2 months or 3 months, then it most likely it's coming from within the hip joint rather than a soft tissue.
Yeah, thank you, Ben. A lot there, but I think that's really helpful to think about the timeline. So you shared there, if it's been going for more than 3 months, even without yet having seen a health professional, be mindful it might be the joint itself, and less than that, be mindful it could be soft tissues, or in the case of a runner, and you gave the example of a female, and I'd probably add on, Ben, to have a suspicion as a male, if a male endurance athletes in particular, that it could be a risk of some sort of bony stress, be it a stress reaction or a fracture up in the femur there. And
can I add one key point there? I think one of the reasons, in my experience, I was looking back, because this condition is so obvious to me, like now, because obviously seen quite a few. When I'm looking back as a junior, I used to think, why are this condition missed? So I would say it's because of 2 key reasons. The first reason is about 70 to 80% of hip pathology will always come with 2 or 3 things. So one of my podcasts, I say hip impingement always come with its friends. So an hip impingement patient or OA patient is very likely to also have back pain, and they might also have some adductor pain or TFL pain. So most of the time, it's very rare to see someone with just hip pathology. They'll have a soft tissue component. They will also have a back component. So that's the first reason. And I think the second reason is you could have 2 patients. You could have 2 runners with, for example, like hip impingement. One, the pain could be on the side. A female, the pain could be on the side. For the male, it could be towards the groin with the same problem. So there is no specific presentation of this hip pathology. So I think these are the 2 key reasons why they get missed. One is most of them will have more than one happening at the same time. And the second fact is it's always non-specific. So it doesn't have a fixed, not everybody has the typical C sign where they keep the hands in the front of the groin. I think that is where you can get that sort of being misled, and if you have a bias in SIJ, you will blame all that on the SIJ. And if you're somebody like a back-based person, you will say it's because of my back in not in alignment. And if you're a soft tissue therapist, you might say, oh, you got a tight hip flexor. So it all depends on the bias you're coming from, isn't it?
Yeah, as a practitioner, it certainly can. And fortunately, I think the world of physiotherapy and physical medicine is moving in the right direction, which is certainly involving a lot of exercise. Ben, in terms of, let's maybe follow a couple of these through. There's so many different ways we could do this. Let's try and make it as practical as we can for the listener. Ben, you mentioned back with the timeline, if it's been going on for more than 3 months, if say someone listening is greater than 45 years and has maybe, as you say, taken a CrossFit or come into some ultra distance distance running or even a marathon attempt, then it could be indicative of some early onset of osteoarthritis. So much fear around the word osteoarthritis and often incorrect beliefs. What could someone do if there has been a bit of a detection of some early onset of osteoarthritis in their hip joint, the ball and socket, if you like, of the hip?
Yeah. The key thing is, it's sort of immediately when people hear the osteoarthritis, they think they have to shut down, stop running and stop training. Otherwise, they'll end up with replacement. So we know that running is quite safe. A couple of studies have shown that even with mild to moderate osteoarthritis, you can keep on running and there is no progression in your osteoarthritis. But there are a few key pointers which will help me to decide whether they're appropriate for running at this stage. First thing is night pain. For me, somebody in a night pain means they need to settle down that first before they start running. And also the degree of stiffness in the morning. If somebody says, I'm struggling, I can't even put my shoes and socks in the morning, they need an optimal drug management first to reduce that sort of severe pain in that. And also the third factor is limping. So I just had a gentleman, I think I saw him Monday on the clinic, and typical male patient, he just came because he was nagged by his wife to come and seek help because he's walking a bit odd. Because hip osteoarthritis, of all the three conditions I mentioned, is the most mildest. It doesn't really bother you. Initially, it's more like a nuisance. You just feel a bit of stiffness. You limp a little bit, but not like you're not screaming in any way. So it's so mild that you can be on it for many, many years or even decades. So the key things is to look out for is that occasional limp, stiffness for a few minutes in the morning, difficulty putting shoes or socks, and when you sit for a television or watch something, when you get up you feel a small niggle. And usually if you ask them, these people have been extremely active. One of the key questions I always ask my patient is how active you were between the age of 8 and 18. So, and we know from latest evidence that CAM morphology and most pathologies happen between the teenage years as a result to what you do with rotational sports. So if you're somebody who's done a lot of football, rugby, squash, so you're more likely to have a CAM morphology, and you might have some chondral lesions, and later 20-25 years you might get symptomatic. And what I find is to become symptomatic, you generally need a change in training volume. So you had a spike. So you already had this sort of hip for about 20-25 years. So you're going to really have a spike. So I think the key thing is to realize it's a slow evolving process. So the first thing I look at somebody is to control the symptoms. So if somebody has night pain, limping, then they obviously need to see a medical practitioner, get the appropriate drugs to manage that. And for a short period, I might do a little bit of deloading, get them on the pole, get them on the Alter-G, aqua jogging or something just to work on that. And I'll give them a good global hip strengthening, just not the glutes, getting your flexors, adductors, get the whole thing working. And one of the things we notice with somebody with an early osteoarthritis is that lack of hip extension. They lose that hip extension, which seems to be the first thing which happens when you get osteoarthritis. And they usually come with back pain because when you lose the hip extension, your back takes the brunt. So you could use a combination of mobility drills to get that hip extension back. There might be a role for some passive techniques from a practitioner to get that sort of range back. And then you could give them some cues on running cues to get them back on when you're running, like pushing the track back, or some active cues to facilitate that active hip extension. And always all my patients will start with a graded running program. So start from an NHS couch to 5K. Once they've done about 30 minutes, then slowly introduce some speed, and finally the hills. So it's always for me the volume first, the speed, and the hills. So that's somebody I would keep on. I never stop anybody with early osteoarthritis from stopping running. So there's no evidence that we have to. But again, we have to be mindful of the symptoms. You've got somebody who is limping, waking up 3 times. There's no point letting them run and get really bad in that form. So control the symptoms, get the strength around, get that hip extension, and have a graded return. I find anecdotally the biggest ones used to be the hills. So usually these patients get symptomatic when they start doing hill work, where we know the hip work becomes really high. And the second one is a lot of speed-based training where the hip flexors and the hamstrings have to work more. So we might have to look into that sort of modifying that sort of variables as well. So it's important to keep them active as long as they can. And many of my patients are successfully running without giving up with those sort of levels.
Yeah, Ben. So I think anyone listening that's active and enjoys running, that has some hip pain and has had a recent detection of some osteoarthritis in their hip, the good news is you don't have to put the running shoes necessarily away, but you do need to work with your practitioner to discover what your limits are, and then try and increase your capacity through some exercise, as you say. Ben, this is a hard question because there's 1,000 things you could say to answer, but can you just point out some of your favourite or preferred just base level hip strengthening exercises? You mentioned it's important to target all the muscles around the hip, the adductors, the glutes, glute medius. What are some of your go-to exercises there, Ben, you might be able to describe for listeners?
Yeah, so I think let's put that into like 3 phases. So initial phase is usually the phase 1, if you think about 4 to 6 weeks, there are 2 parallel lines. So I'd give them a generalized gym-based program with machines because it's good to have bilateral strengthening. So they might have a circuit of simple exercises like your leg extension, leg press, just to get that global conditioning. And at the same time, they'll be having a rehab program where they are doing non-impact based on your assessment. If it's an abductor strengthening, you might do your side lying hip abduction or hip flexor, or if it's adductor, you might start. So based on your assessment, you might pick up the group where you're going to work on. So that could be the first stage where you're having a global strengthening, machine-based, non-functional, because you're getting that sort of global recruitment. And at the same time, they're doing some low-impact training, could be cross-trainer, bike, or pull-based. And then once they've done that stage, when they go to the second stage.
Could I ask on the first stage there, for the continuity, what sort of reps and sets would they be doing heavy loads at this point, or it's just general conditioning?
Yeah. So one of my favorite method of loading with the machine-based is undulating periodization, where for the first week they might do 4 sets of 15. The second week they're going to 4 sets of 12. The third week they go into 4 sets of 8, and the fourth week they repeat back again. So for the first 3-4 weeks you might start bilateral, and then by the time they go to the 4th or 5th week they go into single leg. So I like this cyclical variation every week where you can really get that maximal gains. And studies have shown there is not much difference between undulating and block periodization. So I usually change my sets and reps every week. So first week, 4 sets of 15, 4 sets of 12, and then 4 sets of 18, and then build it up. And I forgot to add, at that time is where I'll also be focusing on the mobility, because strength without mobility means that you're not able to use your muscles quite well. So big fan of using self MWMs with belts. So, the CrossFit bands, which have been taken from the fitness world. So I'll teach them few simple active mobility drills, mainly working on extension and external rotation too, because sometimes you can't improve the internal rotation. So I work on what I can improve on. So they'll be having some mobility drills, some global conditioning with the machine, and also some specific hip work based on my assessment. And what you find is generally with women, the abductors are more weaker, and generally with men, adductors might be more weaker, and somebody from a dance background, the hip flexors are more weaker. So although I don't have much research to back up this, what I've seen through my few hundreds of patients over the years. So that's where I think devices like handheld dynamometer can really be useful, because you can know specifically which muscle group is the weakest, and that's why working with a practitioner is useful. And then once you've done that stage, you can move on to the next phase where you're going into more functional based training. So the key thing is I stay away from squats with this patient initially, because that's the most provocative. So initially I might start with something like a split squat or a split lunge, hip thruster, and a sumo squat, where you're really having external rotation. I don't want the pinching, so I don't really start the barbell squats initially. So my favorite are hip thrusters, the split squats, and the sumo squat. So you're really getting that glute as well as adductor, because we have to remember the adductors are the second most powerful group next to the glutes. So we don't want to miss that group as well. So I might start them on this sort of phase. And so generally I will... Sorry?
Oh, you're sorry, Ben. The split squats, just for clarity, would the listener be doing that with the foot on the ground or with the foot on a chair, like a Bulgarian split squat?
Yeah. So initially I'll keep the fit leg back. I'll start with a simple, split squat, just both the feet on the ground, and then I can progress into a Bulgarian split squat, which is a great way because you can lengthen and also load it at the same time. So one of my favorite. And you could also include the deadlift pattern as well. So the way I normally progress with my hip patient is I'll start working on the lunge pattern as with the split squat. Then I'll move into the deadlift pattern. Then I'll go into the step up pattern, and finally I'll go into the deep squat pattern. So I keep the most provocative the last. So I find that sort of doesn't irritate them. So, and once you have done a good 6 to 8 weeks of this unilateral strength load work, and that might be a time to introduce a little bit of plyometrics, because any sports you're going to have some plyometrics. So you could start with some hops. If you're really cautious, you could start even in the water. You could sort of do various versions. So there has to be some element of plyometric after you've completed a good 6 to 8 weeks of isolated functional training. So that would be a typical, and this takes time. The patients, it's a collaborative journey. And I say to my patient, it's, you're talking about 3 to 5 months, and you're talking to at least 10 to 15 sessions. So it's not a quick fix, and it's, you have to work closely with a therapist to get that full gains. And if you want to avoid surgery, you're not going to get that with 2-3 sessions of just some soft tissue release or dry needling, which might have its role in the initial phase to get the mobility. But that to get back the real tissue adaptation takes time, and that's the hardest thing for me, is getting them on board with the timelines.
You're listening to an expert edition of the Physical Performance Show, featuring UK-based physiotherapist Benoy Mathew on all things hip and groin pain. Support for today's show comes from PhysioCrem. PhysioCrem is a topical massage cream containing natural plant-based ingredients, ideal for the temporary relief of muscular aches and pains. If you're conscious of what you put on your body, you'll be happy to know that PhysioCrem does not contain parabens or hydroxybenzoates. It is clean to use and pleasant smelling, with the smell fading away in just minutes. Its non-greasy formula doesn't leave any sticky residue behind. PhysioCrem can be found at chemists and health stores Australia-wide, as well as via their online store. Jump over to PhysioCrem, that's FISIOCREM, and there you can use the promo code POGO to receive 20% off as a listener of this show, any PhysioCrem product. Hurting sucks, and PhysioCrem have got your back. Support for today's show also comes from Pogo Physio. We exist to help you get back to your physical best following injury. We want everyone who walks through the doors of Pogo Physio to cross what we term your physio finish line. That's where we high-five you and celebrate the fact that you're back to your physical best and that you've completed rehabilitation. In addition to traditional session-to-session appointments, we offer some unique models of care, such as our 2, 6 and 12 fixed fee unlimited access finish line programs and our monthly wellness booster packs, all designed to help you save money and recover faster. To find out more about Pogo Physio's services or to schedule your 1-hour initial appointment, jump over to pogophysio.com.au. For now, let's jump back to Benoy Mathew sharing around all things hip and groin pain. So the 3 phases there, just to recap, were generalized strength programming, functional-based training, and then some degree of plyometric or hopping, jumping type activities.
Yeah, definitely. And sometimes I might get them. Sometimes if I'm a little bit worried about plyometrics flaring up, I might slowly get them back on running on a graded program, make them run for at least a month, and then I might introduce plyometrics. I had few patients where plyometrics flared them up, so get them into some low level of running, 15-20 minutes, and then I might introduce plyometrics. So I think it all depends on your clinical assessment, but you have to have an element of plyometrics. Otherwise, when you start doing some speed work, you will just flare up things. So you have to prepare your body through load as well as to speed, because you need both for any form of training.
Ben, as a practitioner, you prescribe obviously something like a gym program in that first phase. I imagine, though, that would carry over and they're still doing elements of that into that second and third phase, plus some degree of home exercise. How do you find, what's your advice for listeners in terms of the listener that feels overwhelmed with there's so much to do? How do you navigate that with busy patients that you see?
The good news with, all the strength and gym-based, load heavy load-based work is if you are a total novice and your baseline is so low, to build it up, you might have to do about 3 times a week. So, and, working with my clients in London, most can't do more than 2 or 3. So I say to them is to initially have that 6 weeks to build up a base with 3 times a week, and then you can drop it to twice. If you start with just 1 or 2, you don't get that enough gain. So initially you might have to have that 6 or 8 weeks period where you do it for at least 3 times a week, and then you can drop it down to So let me give you. So I'm having a patient currently who is sort of 52, early OA / hip impingement. The one thing about hip impingement and dysplasia, once you get osteoarthritis, the underlying diagnosis is pretty much pointless. It's more of an academic interest. It doesn't really matter. Once you get OA, you're OA. Everything other diagnosis becomes quite irrelevant. So he has a background of hip impingement, but he's got OA. So his program is twice a week gym session and bit of circuit braced, and then he'll finish off with some cardio like a cross trainer. And then I've also given him a home-based program 4 times a week, which he can do easily at home with some simple stuff like bands and gym balls, ankle weights. So 20 minutes he can do it while watching telly or something like that, or even pretty much home-based. So I think that is a doable balance, and I think most people buy that. So twice a week at the gym and 4 or 5 times at home with a home-based circuit.
Yeah, brilliant. Ben, you have given so much there with regards to that sort of example of a runner or someone with early onset of osteoarthritis that then obviously applies for many other diagnoses or conditions of the hip. But can we just speak to the younger athlete or younger person, so sub 45 as an example, who has experienced an onset of pain, and it's more soft tissue based? You use the phrase at the start, impingement. So can you just break down a little bit of this impingement world, which is, I think most listeners will have heard of it and it's commonly thrown around, but there are so many layers to impingement. So can you speak to that first and then talk secondly around some of the treatment strategies that you would employ for the soft tissue stuff as opposed to the jointy, hip joint related pathology?
So I think with the hip impingement, as you rightly mentioned, it's a spectrum. So you could get like a 16 or 17-year-old academic young male footballer, or you could get like a young mom who started hip pain when she started going to the gym. So it's a wide spectrum. So generally, if you're working in primary care or practitioner, you're more likely to see females, and if you're working in a professional sport, it's going to be mostly male. So there are 3 distinct presentations I see in my clinic. One is that young active male, usually anywhere from 16 to 22, who is doing some form of rotational sport like football, rugby, squash or something, and they have intense training routines. They're training 5 days or 6 days a week. So that's one pattern you see for the early one, where the male type. The second and by far the most common type which you see in the clinic is sort of a female, usually between the age of 25 to 35, who is quite active, goes to the gym, classes, runs, and who has that sort of a niggling pain around the sort of outside of the hip, the typical C sign, where if you keep your hands to the sides, it covers the front as well as on the sides. So, and usually the complaints are pain with the classical symptom is pain on prolonged sitting. So there's a patient who will say, I can't drive for more than 20 minutes. I can't watch a movie. So any activity which causes prolonged hip flexion and internal rotation. So when they're going to the gym, squatting and getting out of the car, all those sort of deep flexion rotation is, or they're struggling with a particular squat, or they're going to yoga class, they'll say, I find this particular posture very difficult. And as I mentioned before, the initial symptom which happens way before is that very subjective feeling of stiffness and that sort of blocky thing. And most people try to override it, which usually is not the right thing to do, because you have that anatomical limit. You can't overstretch your anatomy. So they have this feeling of perceived stiffness and they keep pushing it, and then you get more chondral and soft tissue damage, and then it starts getting more painful. So initially you go through the stiffness phase, difficulty in performance, and then it starts affecting your ADL. So you can't sit for more than 10-15 minutes, then you start limping. Then even basic stuff like driving, watching movies become a problem as well. And then you get sort of that sort of late 30s, early 40s, where you get a bit of both, where you get a bit of hip impingement as well as you get a little bit of OA as well. So these are the 3 distinct groups. But most people will be in the 20s and 30s. Now, the trick is when they come to my clinic, sadly, most of my patients come very late. So the key piece of advice I would say is to seek help in the initial phases where you feel that subjective feeling of restriction and a sort of ache after training. And the biggest factors for me are the irritability. So if you get let's have two runners. So you got one runner who says to me, I get pain only after 45 minutes of running or when I do a hill session, or you get another runner who says, I can't even sit for 15 minutes. So obviously my success is very high with that first runner where it's purely on load based on a particular incidence, whereas she's pain free during ADL. She can do most normal things like housework and working quite normally. So those patients generally tend to do well, and generally patients without night pain also do well, because night pain usually is a sign of more extensive labral damage or synovitis. And for me, the big deal breaker is your internal rotation. Suppose you're playing football or professional or any sort of rotational sports, you need at least 20 degrees. So many times I get young males who come to my clinic and they have sort of 10 degrees, 8 degrees, and you can't do football with that. So the level of the symptoms, the irritability, and also the internal rotation. And the last thing is asking the patient what they want to get back to. So if you got somebody who is a personal trainer, who is a yoga teacher, or a professional athlete, I say to them, like, I can get you better by the moment you start going back to the gym or pushing it'll come back. And many patients understand that. And so I think physio or rehab has a better chance. Like with anything, most things, if you pick them earlier, in the first 3 months, if you pick them up, you can pretty much make a big difference and possibly even avoid surgery. But if they come to me at a very high level of decline, so they've stopped going to the gym for the last 6 months, they have not run for 8 months, then I doubt whether you can really make any significant changes with them.
Even with great programming and someone that is willing to put the time and energy into it, the outcomes are poorer if they have left it longer.
Yeah, and because I think what happens is they're more likely to have more extent, because we know the labrum is important for the suction and also prevent secondary chondrolation as well. So if you have extensive damage and you have a chondrolation and also your sensitivity is very high, and you sort of pretty much the whole system gets really sensitized, and you sometimes maybe surgery is the only way in that cases. And I think the biggest one is internal rotation. So you need that range for them. The main aim for surgery is to regain that range of motion. So the surgeons I work with, the first thing that's a clue for the practitioner is when you see somebody after hip arthroscopy, and I see them on the couch, if they don't have that 20 degrees, the surgery is one of the biggest reason for failure after hip arthroscopy is incomplete resection. They don't take it enough, and they end up after surgery they still have the same restriction, and you can bet. So many times I get second or third opinion where patients have come to me after 8 months or 1 year after the hip surgery, and I check the internal rotation, it's like 12 degrees, and before the surgery it was 10 degrees. So it's not really made any change, and you can't really rehab a bad surgery. So in that case, they might end up needing a revision. So I think checking the post-op internal rotation gives a clue whether that really the surgery has been successful as well. So it's a combination. You're not going to push them. So most of the time, is checking the symptoms, how bad it is affecting, and that's where there are a lot of scores for a practitioner. I use a score called the HAGOS. It's a free download where you can sort of see how they're progressing. So I check once in 6 weeks, because sometimes patients are not very honest. They want to be nice to you and they say like, I'm getting better. But you look at the forms, they're still, from 100, they're still at 25. So, out of 100. So, or I had 33. So it's always useful to do, like with the tendon, we use a Visa H or Visa P. It's always useful to use one of the scores because that gives a true idea than purely on a subjective way. So many times patients don't tell you the whole truth because they don't want to disappoint you, and you might think they're making progress, but they're not.
Yeah, gosh, there's so much there, Ben. Just to recap, there's those three groups: the young, active, 16 to 22-year-old involved with often rotational sports. This is in more the soft tissue side of things as opposed to the hard bony joint, if you like. The female, 25 to 35, quite active, running gym classes, etc. And then the late 30s to early 40s, where there can be often a bit of a combination of soft tissues and also the more bony type stuff going on. Ben, What would you say to listeners in terms of the roles of medications?
Yeah, I think for me, there's two things. I keep it quite simple. If somebody has night pain, waking up twice, we know night sleep is one of the biggest healer. Nothing works if you're waking up twice. If you have high resting pain, like if you when you're sitting and you're talking to me in a clinic and your pain is 7 or 8 or 10, and you're waking up twice a night, then for me, I think you definitely need some painkillers. And I think the way I sometimes say, because I've seen hip arthroscopy surgery, watching with different surgeons, once they go in, you see a lot of synovitis. So a lot of the pain is not actually the bone, but the soft tissue inflammation. So I think explain to patient the painkillers is just not about pain. It's about reducing the inflammation, which as we know blocks your muscle recruitment. If you got an inflamed joint, you're not going to, even with the best rehab, you're not going to recruit your muscles. Just like if you have a swollen knee, you're not going to engage your quads. So same thing with the hips as well. If you got an inflamed synovium and the soft tissue, even the best recruitment, the Pilates or any exercise, you're not going to get that. So sometimes you need that 2 to 3 weeks of naproxen or any anti-inflammatory in consultation with your medical practitioner just to calm it down. So usually my calming up phase, somebody comes to me and they're limping in. So usually the couple of things I would do to calm them out. So I'll ask them to take a few weeks of anti-inflammatory water, getting them on the pool, because we know that hydro has the big effect. So even just simple pool walking, swimming with flippers or any supports, just to get that sort of joint range. And the big advice there would be is to restrict their extension. Extension is a double-edged sword. When it's very sore, you don't want too much of hip extension. So I'll ask them to walk with short steps. They can be fast, but not to overstride. So stop the overstride. Don't take into end range hip extension, because that irritates the anterior aspect of the hips. And stop all form of sitting-based training at the gym. No cycling, no swimming, but you can do a little bit of cross trainer or anything, and just really calm it down, because you can't really do much of rehab if you got a very inflamed and a sore hip. So a combination of painkillers, activity modification, reducing your stride length, and also some pull-based activity, and then you can progress into some more non-functional mat-based exercises and progress them from there. So sometimes you need that sort of 3 to 4 weeks of calming down phase. And what I've changed in the last few years is sort of rush. If somebody, if it's taking more than 4 or 5 weeks, I don't hesitate anymore sending them for a guided one-off ultrasound guided hip injection, a steroid, just to calm it down. It's not a serial injection because it makes the job of the therapist as well as the patient much easier. So I've seen a lot of surgeons use hip injection as both diagnostic as well as therapeutic. So if you got somebody and you can't calm their hip down after 6 weeks or 8 weeks, then there's definitely a role for a hip injection, just a one-off one, just to reduce that inflammation and get them back on track and possibly avoid surgery.
So it's not just about medications aren't just about pain. We need to consider that it can be about inflammation as well, and the ability to generate strength gains around an inflamed joint is negligible. So that needs to be heeded. It's also about activity modification to assist with that pain management as well. And I think what you just mentioned is quite profound about the fast walking. I think it's easy to underestimate the impact that does have both on a joint level and also a soft tissue level. I recall previous expert edition guest Dr. Peter Malliaris talking around all things tendon pain and commenting that fast walking can load the upper or proximal hamstring tendon almost as much as intense running.
Yeah, and what I sometimes do is I find like the tall female, long femurs, they have difficulty with that controlling the hip extension. So sometimes I'll ask them for a period of 2 weeks to where you can get that from Amazon or online stuff is a groin brace. The idea of the brace is not to support the hip, it's just to purely to train them to limit their hip extension. So I'll sometimes ask them to wear the brace when they're walking for 2 weeks, and that sort of retrains them to reduce their stride. So sometimes an external cue like a brace or a tape can be useful there, just to retrain that sort of for that short period.
Yeah, that's a great suggestion, Benoy. You mentioned non-functional mat-based exercise. What are a few of your go-to exercises in that space?
Yeah, so I think what you find is I find with most of the majority I see is the female, the mid group, there's always that weakness around the hip abductors and your gluteal engagement. So there's nothing, major. So the important thing we know from studies is the patients with hip impingement seems to have a big issue with getting the pelvis into posteropelvic tilt. So a couple of studies have shown whenever they do any functional task, they go into, the excessive anterior pelvic tilt. And we have to remember the hip and the pelvis, we call it the lumbopelvic hip complex. It's one thing. So you could have somebody with a ridiculously shaped cam, big like a coconut, but no hip symptoms purely because they have good control of the pelvis. So getting that good control of the lumbopelvic complex is crucial because it's too late to change them when they're squatting. So sometimes I've seen Instagram and YouTube where they try to correct their lumbopelvic tilt when they are having like 80 kilos on the back, which I find it's quite difficult to do when you have such a load. So one of my key things is to get that posteropelvic tilt along with hip extension, because the way I explain to my patient is anterior pelvic tilt is locking closing the hip, and posteropelvic tilt is opening the hip. So even that 5 to 10 degrees of posteropelvic tilt can improve your functional hip interrotation by anywhere from 5 degrees and improve your flexion to 10 degrees. So even without surgery, the best way to improve range is to getting the slight posteropelvic tilt. So that's the key thing I want to. So the 3 aims on the mat-based exercises is getting the coordination between posteropelvic tilt and hip extension, and then also working on the small stability muscle, your external rotators. So all the 6 muscles you have in the back, so getting them into resisted external rotation in different position, from 4-point kneeling and sitting, or doing a midfoot walks, putting a band around the midfoot, and finally is working on your lateral stabilizers. So those are the 3 main muscle I try to function. And at that time, nearly all my patients will also be having few classes of Pilates to complement my exercise as well, because that sort of, I think the Pilates teachers are way better than me to get that sort of initial body centering. So the key thing I focus is to get that sort of posteropelvic tilt, avoiding that functional impingement on the front, and also getting that range back. And there are a few exercises which we know irritates the hip. There's nothing wrong with the clamp, but the problem with the clamp is, I explained to my patient, is a clamp is a side-lying faber. A faber is a provocative position. So you won't say a patient to a hip impingement to do 200 clamps a day. So same thing happens. When you do a clamp, you're just irritating. So it might have good recruitment, but the position just irritates the front of the hip. And I find a lot of patients have flare-up. So I never use the clamps with my hip patients. And also when you're doing hip extension, like a bridging, there is no need to take that into end range extension, because the more you push into the end range, you're sort of irritating the capsule and the labrum. So you don't have to necessarily take. So those are the 2 things which usually irritate the hips, is that clamp position and extreme end range hip extension, which is not a good thing for an irritable hip.
Benoy, that's terrific. Thank you. We must touch on, there's so many places we could take this, but being conscious of time, we must touch on a couple of things. This FAI, femoroacetabular impingement, there seems to be a growing awareness amongst the non-professional health community of this, and a lot of misinformation or incorrect beliefs around it. So can you just very practically speak to this concept of FAI, what it is, what it can possibly mean for listeners who may have that floating around in their head as a possible diagnosis, or perhaps it's been formally made. So can you break down FAI for the listener?
Yeah, so femoroacetabular impingement is not something which suddenly came in this century because of a change in lifestyle. It's always been there since mankind. So I just remember, I think a few months back, I was in the Natural History Museum and looking in some of the Egyptians, and I could see a few of cams there clearly on display. So it's nothing. It's around 20 to 25% of the general population have some form of. So some of the statistics I use with my patient is. Across the world, 1 in 4 people will have some form of hip impingement. And if you go to a professional top club, so I'll use Chelsea Football Club, which is the club I support. 3 and 4 will have hip impingement. So if you go for a top football team or a cricket team or any NFL, about 3, 4. So it seems to be a normal morphological variation. So it's an adaptation of the body, either by genetic. The key thing is we know it's a combination of reasons. There's a genetic component, because one of the things is 99.9% of patients I see in my patients with hip impingement are white Caucasians, Caucasian patients. I never see much of Asians or black population. It seems to be a strong link with ethnicity. So we don't understand it yet. So there's a genetic link, and there's a link with your childhood as well. But it's a normal variation. So in fact, you could say if you didn't really have a cam, you didn't really push your body too hard when you are a professional, when you're young. And so it's 1 in 4 we have it, and it can be an extra bone on the femur called the cam, or on the acetabulum, which is the pincer type. Most of the time you have a mixer type. So the $1 million question, I think the reason we still really don't understand is, if it's so common, why do some people develop symptoms? So only a small percentage of develop it. I think we got few theories. I think the key theory is, one theory is overload. I feel there could be an element of early specialization. So there's a lot of studies coming out, especially from the States, saying like early specialization, just doing one sport 5 days or 6 days a week is not a good thing for an active child. So maybe that could be a factor. So you're getting them too early into one sport, too early, and burnout. So many factors, and could be an issue with muscle balance, recruitment. So we really don't know why some people get symptomatic. So a small percentage do get symptomatic. So there are 2-3 key factors. So first fact is, it's a common morphological variation. You'll see that across. There is a genetic component. There's a training element, and a big fear is FA is not destined for hip osteoarthritis. The vast majority of people will have a normal life with hip impingement and will not end up with end stage or a severe OA, which again, we don't know. Why do some people develop? So we only have 1 or 2 facts. We know that people with a very large cam, which is we consider as an alpha angle, which is the way to measure how big your cam, more than 78 degree, they are slightly higher risk than somebody who don't. So we only have few variables. So most patients will not develop into osteoarthritis, and that can be managed successfully. But your chance of being successful with conservative management depends on seeking help early. If you come back to the therapist with extensive soft tissue damage, multiple adaptation, and extensive labral damage, then even the best therapist with the best program and even good facilities like what Brad you have in your centers, sometimes you can't do it. They come to you too late. So that's the thing. So it's a normal variation. It's not a sentence that you will end up with osteoarthritis. And a big fact which I get annoyed is this sort of message by certain surgical groups saying that surgery prevents osteoarthritis. I think we are making the same mistake which we did with ACL. So I think 10-15 years back, you could say people saying if you didn't have a ACL reconstruction, you're going to have osteoarthritis. Now we know that it doesn't make any difference whether you have surgery or not. The incidence is pretty much the same. My gut feeling is the surgery is fantastic for reducing pain and function, but I think it's too early to say that surgery prevents osteoarthritis. So I don't think we have any evidence to show that surgery prevents osteoarthritis. And even I've seen some shocking cases where people have surgery on asymptomatic side. Usually, they have pain on the right side and they go in and have a scan, and the left is also looking bad, and they have prophylactic surgery, and there's absolutely no evidence for that as well. So there's a lot of malpractices happening, and I guess it's having that honest conversation and taking the fear out of it. It's a normal variation. Some people get symptomatic. You won't necessarily get osteoarthritis. There are a lot of things we can do, and surgery is not a guarantee, because a lot of people have surgery thinking that surgery will prevent them osteoarthritis. We don't have any evidence for that at this point of time.
Yeah, wow. Thanks for bringing some perspective around that. So I guess the key takeaway is if you are experiencing hip pain and a practitioner has spoken about this FAI or cam impingement, then unless you're experiencing symptoms, you may not need to be too concerned. And
rushing into surgery doesn't mean that surgery. For me, the surgery is a purely, a decision based on your pain and function and your expectations and what level. So if you're a very high level professional athlete, and if you're a yoga teacher or somebody who needs their body livelihood, then I can understand that they might not have that time, 3 to 6 months to have the break. But rushing into surgery because of fear and by the messages saying that that will prevent osteoarthritis. At this point, it's not evidence-based. So I feel a lot of time people are pushed too early without having a good chance of good quality rehab, which most of the cases can make a difference, and they may not necessarily have to go. And the key fact people going to surgery have to realize is hip arthroscopy is not like knee arthroscopy. It has the same element of involvement and needs the same respect as an ACL reconstruction. If you look at some of the American protocols, they'll say you can go back to the sports in 4 months. I don't know how they do it, but in reality, it takes me 6 to 9 months or even up to a year. So I say to them, it takes 1 solid year. And are you really sure you're going to go through all this sort of hassle, and realize how, because sometimes they're not given the information as well. So it's not a simple keyhole surgery. You go and clear it and you're back running in 2 weeks' time. So even one of the running studies have shown that it took them 8 months to get back to full function to running. So that was a group in recreational runners with high good function. So it's not a guarantee that even you get back that you're going to start running in 2 or 3 weeks' time. And I think this is where a therapist can make a big difference. Is something which we've started working in a clinic, is one of the biggest predictor of surgery post-op is osteoarthritis. Obviously, if you have arthritis, you won't do well surgery. Second is your pre-op status. If you are in a good nick, if you're still going to the gym, you're still running, and you go for the surgery, you're going to do well. It's not a surprise because surgery is being like knocked by a car or something. You're going to go downhill. So what we tend to do in the clinic, even people going for surgery, we give them a solid 12 to 14 weeks of good prehab, and we find that makes the rehab post-op much easier. Patients are back running quicker. So I think even though sometimes we can't help patients and not avoid surgery, we can still help them by giving them very solid prehab to help them back to good function and thereby reduce their difficulties post-op.
And the prehab is going to some way mirror what the rehabilitation would entail, correct?
Yeah. So we got some great research from Jonna Kemp, better recently on of the conference. She's, a fantastic researcher where she's, looking at the cohort, and she's come with a few simple markers. So simple things like your side plank, she found like a side plank less than 34 seconds, single rise test where you basically sit to stand without arm support. For ACL, it's 22. For hip arthroscopy, it's 16. So we try to get all these markers before the surgery. So we aim for symmetry with inside, get the hop test, get the hop distance same with the 90%. Get the side plank strength at least 30 seconds more. Get the single rise test more than 16. So these are simple things you can use in your clinic.
Yeah, brilliant. Ben, 2 final areas here. Practical tips for sitting. You mentioned their modifying activities. If someone is getting some hip pain with sitting, what things practically might they be able to do to help reduce some of those symptoms?
So the key thing we find is a simple rule I use with my patient is the hips should always be 2 inches higher than the knees. So whatever you do, whether it's sitting in an office. So first thing is we find is to reduce your time in very low sofas and very unsupportive places. You get this sort of some fancy sofas where you don't get any support. You just like a cockpit or some chair. So even if you have a car like that, you can go and get like chair races. You can get from some of the shops to increase the height. So simple by adding a little bit of addition so that the hip has to be physically at least 2 inches higher than the knees. That's the key thing. And the second thing is avoiding flexion-based training excessively. So things like your deep squats, cycling, rowing, sprinting classes, that might not be appropriate in the stage 1 where you are inflamed. So avoiding that sort of constant bombardment into end range and irritating the synovium and leading to muscle inhibition. And also things like, I think we should be doing is, all of us should be doing is getting up every 20 to 30 minutes. So for me, the best, so this is a tip I would say for a therapist, the best way to assess somebody's progress. For me, every few weeks, I always ask my patient is, how much can you sit without pain? So you can have a patient who could be doing like 3 marathons, doing double pull-ups. You can do all crazy stuff. But for me, if you can't sit for more than 10 minutes without pain, he's irritable. It's simple as that. Yeah. As a human being, you should be able to sit for at least a good 45 minutes without pain. So I get these patients who come and say, I can do this, I can do that. I just turn back and say, can you sit for 10 minutes without pain? I say, no, I can't. So clearly, we need to go back to the basics. So sometimes the simple things matter here. And for me, the best and a simple marker you can use with your hip patients is sitting time. How much can you sit? So that is a great way. So when somebody comes to you, they can only sit for 8 minutes, and after 2 months, they can now sit for 45 minutes. That's a great improvement there. So for me, those sort of simple ADLs are bigger than your personal PB or your marathon time and things like that. Because sometimes the type A personality, they try to use fitness. I always say you can't use a fitness solution to a medical problem. So just because you can, push your body extremely in the gym doesn't mean like you have it. You can get rid of pathology. That's where I think it becomes blurred between fitness and pathology. When you have that sort of when you can't sit, you're struggling, you have night pain. There's no point pushing and killing yourself at the gym. You need to get that sort of appropriate medical healthcare professional to sort it out. By more training, it's not going to sort it out there.
Yeah, that's so profound. You can't use a fitness solution to a medical problem. Ben, finally here, if you could, boil everything you've learned through your extensive career, that's been both, clinical and now some degree of research, but many years of teaching as well, into one piece of advice. This is almost an impossible question, I understand. But what would be the one key piece of advice Ben Matthews would give to listeners if they are experiencing some hip pain? If it could only be one thing.
Yeah. So I think key thing is, as a runner or anyone active, you don't have to rush to a healthcare professional for every niggle. But one thing I find that many times when people come to my clinic, I just have a sigh of sadness where I felt if I see them like a few months ago, I could have possibly made a big difference. So I think if you have chronic hip and groin pain for more than 6 weeks, it doesn't mean like you have to need an X-ray or an MRI or rush into anything. But I think it's very sensible to seek opinion, because hip and groin, if you catch them much earlier, your chances are very high, and you could pretty much prevent from going into extreme procedures and big surgeries and things like that. Because most things, your body is extremely clever, and so don't ignore that sort of long non-niggles you're having in your hip and groin. Don't keep pushing that sort of stiffness, saying that I've got tight hips. It could be a body saying that it needs that help. And even something like a simple modification in your training, a few little tweaks is all you need to have that sort of return back to function. It doesn't mean like you need an extensive. So I find like, and this is where I think women, I find they do really well, is they come very early. Most of my female patients come to me like within a month. They have a bit of niggle, they don't have any problem. Whereas the men, they usually pushed by their wife or partner, or somebody noticed them, they're just dragging their leg or something like that. So many times patients wait till there is extreme pain. That is too late, in my opinion. When you have drop in performance, when it's affecting basic stuff like your ADLs, getting there to somebody, again, like with this, because it's a specialized area, it's seeking people. That's where I think runners are very good in that. They know who are the best therapists for running, so they'll always go with the word of mouth there. So I think is asking with your friend, people at your gym or somebody in your running club who is because it's a very niche area and it needs a lot of things can coexist. Is checking with them is who would they recommend as somebody as a go-to person for a complex hip and groin. And if you seek them all, and in fact I say to them, you can save a lot of money by going early, because you might only need 2 or 3 sessions, whereas you go back after 1 year, you might end up with 15, 20. So it's in your best interest to seek early and fix it early, and thereby avoid unnecessary, more invasive options.
Absolutely brilliant, Ben. In the fullness of the topic, I have almost completely missed the pain in the back of the buttock or hip there, and I know time constraints are on us, but if you just basically, what would be the key things to keep in mind of if someone's getting pain at the back of their hip or around that buttock region?
Yeah, the funny thing about the buttock pain is most of the reason it's usually referred pain. So the 3 ways I look at when somebody comes with a chronic buttock pain is obviously rule out the back and the side J. Most likely is they have an underlying back issue which refers in. So, and then second thing is about 30 to 40% of patients with hip pathology will have some form of buttock pain. So your early OA, your hip impingement, a lot of them come with buttock pain. So make sure that you rule out your hip. So that's why a lot of times they end up with back clinics and you don't X-ray, they got quite severe OA. So a lot of people end up having back surgeries when in fact the main problem is the hip. And then you think of your local pathologies, So by far the most common 3 pathologies I see in my clinic, especially in a runner, is the proximal hamstring tendinopathy, which I fortunately, is a great work from Tom Goon and all the stuff published along with Pitt Malalis. There's more awareness on that. So because historically we just used to stretch them and end up with more problems. So we got very good loading protocol. So proximal hamstring tendinopathy is number one, HSC. Second thing is this sort of umbrella term, what we call the deep gluteal syndrome. So I hate the term piriformis because you can't isolate the piriformis. So it could be any of those 6 muscles. So generally those patients will have the buttock pain is severe, and there's very specific clinical test where you can sort of get the confirmation. And finally you get a very rare condition which is called the ischiofemoral. Currently I've got 2 patients referred by other physios. So a large portion of my cases is patients referred for other physios for a second opinion. So these patients are usually diagnosed as proximal hamstring, and whenever they do any end range hip extension, they get severe pain. So it's called ischiofemoral impingement, where you get squashing of a small muscle. Again, most common in the women as well. So those are the 3 pathologies. So just like the groin, we also seem to now understand that there's more things complex. Sometimes a little knowledge is a blessing. Once you know more, then you end up having more complexities. Now we know that the buttock region also has many pathologies, and very, very rarely, especially with the runner, always keep in mind like a stress fractures and stress reaction, especially to the sacrum and things like that. And that's a very difficult one because the pain is very vague and diffuse. So I've seen few middle-age, or a late. I've seen all of them. I've seen has been men in the 50s where they've suddenly gone into minimalistic shoes and 4-foot strike, sudden change in the foot strike or in the shoes, increase in load, and they end up with this sort of stress reaction and stress fracture of the sacrum, which is a nightmare to treat. You're sort of 6 months to 9 months off running. So always keep that in mind, especially when you're dealing with that sort of the master athlete, which we are seeing a lot more recently. Yeah,
that's great. It's uncanny. I actually have 2 ischiofemoral impingement cases in my diary at the moment as well. So that's uncanny. What's that clinical test? So out of pure professional self-interest here for the deep gluteal syndrome that you mentioned that you would use.
Yeah. So the deep gluteal syndrome is for the couple. It's a cluster like anything else. I'm never going to be excited with just one test because, like we know, the most tests on the hips are not so specific. So for the key question is the most of them will have back pain, which makes our job more harder. So the buttock pain has to be higher than the back pain, and the number one symptom has to be sitting. Usually sitting is the same, just like FIA, the main symptom is sitting. So I can, maybe we can, there are three specific tests. One is called the active piriformis test, where you put them inside lying and basically clamp position and do like repeated pushing against your hand at least 4 to 5 times, and that should reproduce their buttock pain. And there is another test called the seated piriformis test, where you get them to the edge of the bed, legs are dangling, and you really take them into flexion, adduction, and internal rotation. And just like the carpal tunnel test of your hand, you hold them for about 30 to 40 seconds and you get a bit of tingling sensation as well. And the final test is your standard piriformis, where you keep your cross leg and then pull the opposite leg, and you should get the deep, feeling. So at least one of those tests should be positive, along with the history. And when you palpate, so a simple way you can do that is if you draw a line from the greater trochanter to your PSIS, it's somewhere in the middle is that sort of what we call the subgluteal space. You should have the tenderness. So again, it's one of the areas you should have some local tenderness. Although you can't say specifically it's piriformis, you should have some subgluteal tenderness. That's sort of midline between your PSIS and your greater trochanter. And based on all this cluster test, your history, your objective finding, and a palpation, then I think you can say with some good confidence that the patient has some deep gluteal syndrome, which is the new name for piriformis, because the more and more we know about science, we know that we can't be very specific. Same like a subacromial pain syndrome of the shoulder or something like that. A greater trochanter pain syndrome, we sort of using more generalized term rather than saying this. It's a controversial topic where it's overdiagnosed, and some therapists believe that it doesn't exist. Like most things in life, the truth is somewhere in the middle. Yeah. It does exist, and it's a small subset, but it's overdiagnosed as well. So sometimes it's just a bit of a posterior gluteal tightness because some running form or something like that. So, and the good news is it can be corrected quite very successfully with conservative management, and I never heard of anybody needing surgery or anything like that.
Yeah, no, brilliant. Ben, thank you. You are a wealth of knowledge, and your ability to break down very complex topics to something that can be practically taken away is terrific, and certainly appreciated by myself, and I know the listener. Finally, Ben, physical challenge for the week. every guest, expert editions, featured performers, interest editions, coaches' corners, they all issue a physical challenge. What is Ben Mathew's physical challenge for the week to listeners going to be?
Yeah, I think the best way to really push your hips to the limit, and where obviously, you know, let's assume you don't have any symptoms and you don't have any pain. My sort of end point with all my hip patient runners is hill sprints, because there's nothing better to get your glutes engaged and working with hill sprints. So if you've done your, once a week, if you can add 3-4 hill sprints, you're going to see a big improvement in your running pattern, and also in your engagement of your hip muscles as well. But again, the key thing I would say is you need to have a baseline of strength. It's not for the novice. So if you feel like you need to add a little bit more extra, I would definitely include a bit of hill sprints along with your runs.
Brilliant. And Ben, where can listeners find out more about you, or even shoot you a question if they would like to do so?
Yeah, I think I'm there on most days on Twitter. So maybe I can give the links to you at Function to Fitness. And for my private patients, along with my Central London practice, which I share with my friend and colleague Glenn Robbins. We're based at Harley Street Physio, so pretty much in Mayfair. So we offer pretty much an exclusive lower limb, a clinic where we see a lot of this complex. And the great thing which I'm seeing lately is therapists coming for a second opinion, and we get patients from all over the UK, and along with the therapist, and we design a program. We see them like once or twice, and they go back to their therapist with more because sometimes in the distance we can't really see everyone around. So it's great to see there's more communication among therapists. So that's something which we have done, which is great for the patient. So we set up a plan, and then the local therapist can sort of take over from there as well. And so I've got a website as well, functiontofitness.co.uk. But Twitter and my workplace is where you're going to see me most. So that's sort of my links there. And for somebody who's interested in our courses, so we pretty much you can see all of our course details on Twitter. So we pretty much, I think we started in Dubai, South Africa. I think we might be going to Belgium and other places. So we try to do our bit on raising awareness on hip and groin. So, and obviously see some new places on the way as well, which always is a good thing.
Absolutely. And to clarify, it's Function to Fitness. That's the numeric number 2 in between those two words, function and fitness. Ben Mathews.
And my email is functiontofitness@gmail. So I can give you this link, so maybe you could add to the show notes or something there, So if people want to touch base on anything, I'm more than happy to do that. Absolutely.
Well, that's very generous to include your email there as well, Ben. Function2fitness@gmail.com. So thank you, Ben Mathews. It's a Friday evening, London time. So really appreciate you taking the time out to share around this topic for the listeners. Thank you.
Yeah, thanks, Brad. I hope it was useful for your listeners.
So there you have it, another episode of the Physical Performance Show. And I trust you found today's sharings by Benoy Mathew helpful. If you did and you'd like to follow Benoy or share some feedback, maybe what you learnt or further questions that you have, then as Benoy mentioned, he's prolific over on Twitter, and you can find Benoy at Function2Fitness. Now that's function as it sounds, to the numeral, and fitness with one N and one S, FITNES. If you'd like to provide me with feedback from today's expert edition or ask a question, it's at Brad_beer on both Instagram and Twitter. A big thanks to you, the faithful listener, for your ratings, reviews on iTunes, and also your subscribing to the podcast from whatever your favourite podcast player is. A big thanks this week to show listener Dave Dog 87, who rated the show 5 stars and commented, "Thanks Brad and the team for putting together this great podcast each week. The guests on the show are inspirational and very interesting, and Brad does a great job interviewing each guest. Highly recommended. Thanks again." Dave, thank you for taking the time to leave the review. And to say thanks, drop me an email, b.beer@pogophysio.com.au, and we'll post out to you a signed copy of the bestseller You Can Run Pain Free, which is now in its 2nd revised and expanded edition. So thank you, Dave. Big thanks also to the good folk who make the Physical Performance Show each and every week possible. Daryl Misson, all things audio engineering, Matthew Walding, all things graphic design, and Susan Wilkin, all things show administration. Of course, another big thank you to Physiocrem, whose support of today's show makes it possible. Don't forget to jump over to the shop, physiocram.com.au, and there you can receive 20% off all your Physiocram supplies. And be sure to jump over to the Physical Performance Show's Instagram handle over at Physical Performance Show. And there on the URL, you can leave your name and details to go into the draw to win an awesome Physiocram prize pack to be drawn in a few episodes' time. So jump over at Physical Performance Show and follow along, and do leave your details to go into the draw for that great Physiocram prize pack. All right, coming up on next week's episode of the Physical Performance Show, we jump back over to a featured performer, and that is none other than Tim Don. Now, some of you may know Tim as the man with a halo. Tim is a professional triathlete, and just 2 days before the 2017 Hawaii Ironman Triathlon, Tim was hit by a truck while out training, and he fractured his C2 vertebrae. Now, Tim is just a matter of weeks out from the 2018 Hawaii Ironman World Triathlon Championships. And on next week's episode, Tim shares the highs, the lows, and the learnings of his incredible overcoming that adversity to get back to winning an Ironman Triathlon and qualifying for the World Championships. You're not going to want to miss it. Until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.